Hello everyone. So as a part of the continuation of INI-CET series revision, today's topic for revision will be the medical emergencies. So in that medical emergencies, the topic which I will be discussing is the various differential diagnosis of headache and as well as its treatment. So I'll be giving you various clinical scenarios and as well as multiple options, and you should identify which clinical scenario or what is the diagnosis of that clinical scenario. Right. So now these are all the options and these are all the clinical scenarios which I'll be discussing now. The first clinical scenario is a 40-year-old man complains of severe headache. Right. So this is very important. Severe headache of sudden onset 4 hours ago, likened to be kicked in the back of the head. So it is looking like kicked in the back of the head. He has vomited twice and is now feeling stiff in the neck. So among the options which has been given to you, what is the likely diagnosis? So neck stiffness, right? What are the important differential diagnosis for the neck stiffness? One is your meningitis, and another important differential diagnosis is subarachnoid hemorrhage. Neck stiffness along with headache. But in case of meningitis, like the individual will have high grade fever, the individual will also have photophobia. So your meningitis, we can rule it out. And in meningitis, like sudden in onset of 4 hours ago, the clinical picture is less likely. So the clinical picture, it is suggestive of subarachnoid hemorrhage, because the description of subarachnoid hemorrhage, like it is severe form of headache. That is what you will see in case of subarachnoid hemorrhage. So the answer in this clinical scenario is subarachnoid hemorrhage. So one important point in favor of subarachnoid hemorrhage is neck stiffness with no fever, with no photophobia. And what are the causes for subarachnoid hemorrhage? Subarachnoid hemorrhage, it is usually caused by trauma. So head trauma, right? This is one of the most important cause for subarachnoid hemorrhage. And what are the other causes for subarachnoid hemorrhage? That is rupture of berry aneurysms. And what is the most common site for berry aneurysm formation? That is at the junction of anterior cerebral artery with the anterior communicating artery. That is the site where the berry aneurysms are very common. And the second most common cause for subarachnoid hemorrhage will be rupture of berry aneurysms. Now, there are certain clinical conditions which can predispose the individual to develop the berry aneurysm. Mainly connective tissue disorders like Ehlers-Danlos syndrome and renal pathology like polycystic kidney disease, coarctation of aorta, and disease states associated with high blood pressure. These are all basically disease states associated with high blood pressure. So in these clinical scenarios, there is high chance of berry aneurysm, and when these berry aneurysms rupture, there is chance of subarachnoid hemorrhage. And what will be the description of the headache? Kicked in the back of the head. That is what is the description of the headache in case of the berry aneurysms. That is subarachnoid hemorrhage. Now, what is the investigation of choice, or what is the first line investigation? The first line investigation is CT scan of the brain. Now, this particular CT scan of the brain, it can be negative in almost 10 to 15% cases of subarachnoid hemorrhage. But when you are suspecting subarachnoid hemorrhage, but CT scan is negative, then what is the next most important investigation is the lumbar puncture. Right? Next most important investigation is lumbar puncture. Now, what is that you will find in the lumbar puncture? So, how will you confirm subarachnoid hemorrhage is? It is confirmed by the presence of xanthochromia. Right? Xanthochromia. And why does, or how does xanthochromia results from? Xanthochromia, it results from denatured RBC mixed with the cerebrospinal fluid. That is how the xanthochromia occurs. And for the development of xanthochromia, it will take almost 12 hours. Therefore, lumbar puncture should be delayed for at least 12 hours after the onset of headache. This is a very important point regarding the subarachnoid hemorrhage. So, and whenever you do a CT scan, right, whenever you do a CT scan, where exactly you find the blood? The presence of the blood will be in the sylvian fissure, and the CT scan that you have to do is non-contrast CT scan. And then how will you confirm, or like how will you make out it is due to rupture of berry aneurysm? That is by cerebral angiography. When you do cerebral angiography, you can see the leakage of the aneurysm. So when there is a leakage of aneurysm, what you can do is either clipping or coiling of the aneurysm can be done. So this is about the subarachnoid hemorrhage, where the individual will have a very severe form of headache, neck stiffness, but there will be no fever or there will be no photophobia. Now you take the second clinical scenario. A 40-year-old businesswoman complains of headache that feels like a tight band around her head. So the classical description of tight band-like headache, that is a classical description in case of the tension headache. And she is a businesswoman, definitely you have a stressor. And how will you diagnose this tension headache? So diagnosis requires the absence of signs and symptoms of other types of headache. Basically, it is the diagnosis of exclusion. And the treatment, if you take, like the best remedy is you need to avoid the stressors. Okay, so the stress management is the very important form of the treatment. One point you need to be very much aware is the usage of analgesics. Chronic use of analgesics, it can lead to rebound headache on withdrawal. So that is the reason why chronic usage of analgesics for the tension headache is usually avoided. And the other preferred drugs are the antidepressants. Antidepressants are sometimes prescribed, although the benefit is uncertain. Sometimes they are being prescribed because in order to reduce that particular stress, or the individual has to come out of the depression. So this is about your tension headache, where the description is given as the band-like headache. That is a classical description of the tension headache. Next, then the other important clinical scenario, if you observe here, a 55-year-old woman presents with a headache that has lasted few weeks. She gets pain in her jaw during the meal, and her scalp is tender on palpation. So you see the classical description. Scalp is tender on palpation and there is pain in the jaw during the meal, and age of the patient is 55 years. So among the options which has been given to you, this is a classical description suggestive of giant cell arteritis, or so what is another name for the giant cell arteritis? It is also called as the temporal arteritis. So in case of giant cell arteritis, the age group at which you will see this is about 50 years. That is the age where you see this temporal arteritis or giant cell arteritis. And this temporal arteritis or giant cell arteritis, it is a form of large vessel vasculitis. There are two important examples of large vessel vasculitis. One is temporal arteritis, what I am describing now. The other one is the Takayasu arteritis. These two are the examples of the large vessel vasculitis. And what will be the classical description in case of this temporal arteritis? The individual will complain of unilateral headache. The individual will complain of unilateral headache. And there will be scalp tenderness. Now, why do you think that there is scalp tenderness? This particular scalp tenderness, that is mainly because of inflammation of the temporal artery which is present over the temporal area. And that is the reason why the patient is giving you the examination finding of scalp tenderness. And what is this pain in her jaw during meal? That is nothing but jaw claudication. So why do you think that the patient has developed jaw claudication? Because you take the muscles of mastication, that is medial and lateral pterygoid, masseter and temporalis. These muscles are supplied by temporal artery. And here, how is the temporal artery? The temporal artery, it is inflamed. So the blood supply to the muscles of mastication is reduced, and that is the reason why the patient is complaining of jaw claudication. Now, what is the other important vessel that is affected in patients with the temporal artery? The other important vessel that is affected in temporal arteritis is the ophthalmic artery. So within this ophthalmic artery, we have what is called the posterior ciliary branch. So when the posterior ciliary branch of ophthalmic artery is inflamed, there is increased risk of blindness, right? There is a risk of blindness. That is if the disease is left untreated. So immediately once you diagnose this temporal arteritis or large vessel vasculitis, like you need to start the corticosteroids. So corticosteroids, they are considered as the drug of choice, right? Corticosteroids, they are considered as drug of choice. And how will you investigate these patients with the temporal arteritis? See, temporal arteritis basically it's an inflammatory disorder. So markers of inflammation, what are the markers of the inflammation? That is ESR and as well as CRP. They are elevated in these patients with the temporal arteritis. But how will you confirm the diagnosis? The confirmation of the diagnosis is by the temporal artery biopsy. So when you do temporal artery biopsy, you will find out that there is granulomatous inflammation, right? And even your Takayasu arteritis, which is a large vessel vasculitis, you will have granulomatous inflammation, but the presentation is different. It is called pulseless disease, that is Takayasu arteritis. Giant cell arteritis, you will have granulomatous inflammation, and we have some small vessel vasculitis where you have granulomatous inflammation within the vessels, that is Church-Strauss syndrome and Wegener's granulomatosis. But there the vessels which are affected is different, and it is a small vessel vasculitis. So now the point is, as the disease may not affect the part of the artery that has been biopsied, treatment should be continued even though the biopsy is negative if the clinical suspicion is high. So the place from where you have taken the biopsy may not be showing the granulomatous inflammation. So you should not think that it is not giant cell arteritis. If the clinical suspicion is very much highly suggestive of giant cell arteritis, irrespective of your biopsy, you need to start the corticosteroids. And these giant cell arteritis, almost in 40% of patients, right, they overlap with the polymyalgia rheumatica. So what is this polymyalgia rheumatica? Where there is stiffness of the shoulder girdle and as well as the hip girdle. So, and in between these two, stiffness of the shoulder girdle is more common than compared to that of the stiffness of the hip girdle. So that is about your giant cell arteritis, where the presentation is like unilateral headache, scalp tenderness will be there, and these individuals, they are at risk of blindness because of the inflammation of posterior ciliary artery, which is a branch of ophthalmic artery. Investigations, ESR and CRP is raised. The confirmation of the diagnosis is by your biopsy, which will show you granulomatous inflammation. Drug of choice is steroids. Then now you see next important clinical scenario with headache. A 30-year-old man complains of rapid onset pain around his left eye, right? Rapid onset pain around his left eye every night for the last 2 weeks, associated with lid swelling, watery eye and as well as flushing. He suffers from these bouts every 3 months. What is the clinical diagnosis? So among the options which has been given to you, so first of all you see this clinical scenario. It is the one which is seen in males. The individual is having bouts of headache. The description you see, bouts every 3 months. That means the individual is having clusters of headache periodically or episodically. And there is also lid swelling and watery eye. So this particular classical description of headache, you will see that in case of the cluster headache. Cluster headache, please remember, it is the one which is very commonly seen in males rather than females. And what is the chance of recurrence? They present with recurrent brief attacks of headache. And this particular headache is particularly around the eye. Right? It is particularly around the eye. And along with the headache, it is also associated with the autonomic symptoms. Like what are those autonomic symptoms? Like nasal stuffiness, conjunctival hyperemia and as well as the Horner syndrome. Now, in case of Horner syndrome, like what are the components of the Horner syndrome? The components of Horner syndrome is ptosis, meiosis, enophthalmos, anhidrosis and loss of ciliospinal reflex. These are the components of the Horner syndrome which can be there in cluster headache, right? And the clusters usually they last between few weeks and a few months as well. And how do you treat this cluster headache? The first line treatment for the cluster headache is high flow oxygen, right? So high flow oxygen, it is the first line treatment for acute cluster headache. And the other drugs are like sumatriptan injection and as well as gabapentin or pregabalin should be given. And what are the drugs which are given for prophylaxis of the cluster headache? We give a calcium channel blocker, that is verapamil. Actually, verapamil, it is a very important calcium channel blocker, mainly given in the treatment of PSVT, paroxysmal supraventricular tachycardia. Verapamil, and the other alternative drug is diltiazem. And the other prophylactic treatment for the cluster headache is greater occipital nerve block. So this is about your cluster headache. Please remember, it is commonly seen in males and the headache is present around the eye. The patient presents with the autonomic symptom, that is tearing from the eye and conjunctival congestion. The first line treatment will be high flow oxygen, and the episodes of the headache, it occurs in clusters, right? And the last important clinical scenario, a 24-year-old woman complains of unilateral throbbing headache lasting for nearly around 6 hours, associated with vomiting and photophobia. She has had several episodes in the past. So what is this clinical diagnosis? Now the description itself, that is unilateral throbbing headache associated with vomiting and photophobia, that is a classical description in case of the migraine. So, and this particular migraine, we have two forms, that is migraine associated with aura and migraine without aura. And in case of migraine, the acute attack of migraine, the drug of choice for acute attack of migraine is the sumatriptan, right? Sumatriptan is the drug of choice for acute attack of the migraine. And for prophylaxis, what are all the drugs which we can give for migraine? We can give calcium channel blockers, we can give beta blockers, we can give tricyclic antidepressants. So these are all the prophylactic drugs given for the treatment of migraine. So for today, these are the important clinical scenarios about the headache. And tomorrow I will discuss few more clinical scenarios of the headache where you have head trauma, and along with that their respective treatment. So with this, I'll wind up this session. Thank you very much. See you tomorrow again.